So today we're looking at a 33-year-old intravenous drug user who's come in with groin pain, back pain, and fevers. Right away, based on that clinical picture, our minds are heading towards an infection, particularly something affecting the bones and joints, which is what we'll explore in the imaging. Starting with the AP pelvic radiograph, we see widening of the symphysis pubis. There's also joint margin irregularity and periarticular lucency, all of which suggest there's some infection brewing around the pubic symphysis. Now moving on to the MR lumbar spine, and this is where it really gets interesting. The T1 weighted images show diffuse reduction in bone marrow signal, which is pretty indicative of infection. We also see loss of disc height at L5S1, along with irregularity and erosion of the posterior end plates. That's really pointing towards discidus. But what's even more striking is the epidural extension of the infection. There's subtle peripheral enhancement of the end plate erosions and diffuse enhancement of the epidural soft tissue, which is consistent with a phlegmon. This phlegmon is actually indenting the anterior aspect of the thecal sac and extending around both L5 nerve roots, explaining the back pain this patient is experiencing. Now, the MR pubis gives us more clues. We see high stir signal within the pubic rami, along with fluid signal in the symphysis pubis joint. That's not normal. Additionally, there's bone marrow enhancement centered around the symphysis, with soft tissue extension on the right side, consistent with a phlegmon again. Surrounding soft tissue also shows high signal, indicating edema in the adductor muscles on both sides. So what we're looking at here is septic arthritis of the symphysis pubis with underlying osteomyelitis in the pubic rami. So far the diagnosis is clear. We've got pyogenic discidus at L5S1 with an associated epidural phlegmon and septic arthritis of the symphysis pubis with osteomyelitis in the pubic rami. Now let's break this down a bit further by diving into vertebral osteomyelitis. This condition can be caused by either pyogenic infections, like in this case, or non-pyogenic infections, such as tuberculosis. The most common culprit in pyogenic osteomyelitis is Staphylococcus aureus, and it accounts for up to 45% of cases. With our patient's history of intravenous drug use, it's pretty likely that the route of infection was systemic bacteremia, so bacteria in the bloodstream has seeded both the spine and pubic rami. Clinically, vertebral osteomyelitis presents with back pain, fevers, and other systemic signs, which fits this patient's presentation perfectly. On imaging, pyogenic osteomyelitis typically shows loss of disc height and low signal on T1 weighted images due to bone marrow edema, with high signal on T2 weighted images. And that's exactly what we're seeing here in the lumbar spine. There's also enhancement post-contrast, which further suggests a phlegmon or even an abscess. Now, it's also worth touching on tuberculous spondylodiscidus, which can sometimes look similar, but there are key differences. TB usually spreads along the anterior or posterior longitudinal ligaments and tends to spare the intervertebral disc. You'll also see paraspinal abscesses more often in TB, whereas disc abscesses are typical of pyogenic infections. But with the imaging and clinical history we have here, we're clearly dealing with a pyogenic infection, likely due to Staphylococcus aureus. So what's the plan for managing this patient? First, we need to do a diagnostic aspiration of the joint or disc to get a sample for microbiological analysis. Find out exactly which organism is responsible. That'll guide us on the best antibiotic treatment. Then the patient will need IV antibiotics, specifically tailored to whatever bacteria we identify. We'll also want to image the rest of the spine to make sure there are no other infected areas. Vertebral osteomyelitis can be pretty aggressive, especially in cases like this where intravenous drug use is a factor. Without prompt treatment, you can run into issues like spinal instability or even neural compromise. So, catching it early with imaging and starting treatment fast is absolutely key. Thanks for sticking around, and as always, if you enjoy these deep dives into radiology, check out our Radiology Made Easy YouTube channel. Make sure to subscribe for more case studies and discussions. Stay curious, and I'll catch you next time.